Next, Anthony DeMaria and Dr. Sakis Themistoclakis, head of the EP lab at the D'Angelo Hospital in Venice, Italy, discuss long-term follow-up. Can we stop anticoagulation?
Welcome to ACCEL, Sakis.
Thank you.
And perhaps we might start with even the beginning, assuming that most patients who are coming for ablation of atrial fibrillation, let's say, are on anticoagulants. Should they be stopped for the procedure?
In the past, the approach was to stop the Coumadin and the traditional approach and bridging this therapy using lower weight molecular heparin. More recently, have been performed studies to do this procedure on Coumadin, and the results of this study shows that there is an advantage to this in terms of reduction of embolic event and also a reduction of bleedings. In particular, there is avoiding the bridging immediately after the procedure. There is a significant reduction of the bleeding growing in the location where we are make the punctures for the access. This is one actually of the approach recommended today also in the majority of guidelines to do the procedure on Coumadin in the therapeutical range. This not means that we have to avoid anticoagulation with unfractionated heparin during the procedure. We have still to use it and to maintain an ACT between 3,050-400 for all the procedure. Of course, when we are doing this approach, we don't need to use a continuous infusion of heparin. A bolus is enough at the beginning of procedure to maintain this value ACT for all the procedure, and just in case repeating the ICT, we repeat extra bolus, avoiding a continuous infusion.
Does the same apply for the new oral anticoagulants, the so-called NOACs?
We have less data for this. Mostly of the new anticoagulants, mostly of the data on the new anticoagulants are coming for the dabigatran, and in most of the case, dabigatran was discontinued before the procedure. Most of these were 12-24 hours before the procedure, discontinuation of this drug, and restarted few hours after the sheath removal. This has an advantage to avoid, in any case, the bridging with heparin after the procedure that reduce the risk of complication to the vascular access. The data on dabigatran are quite controversial. There are different papers. And for the rivaroxaban, we have very few data, just one paper published right now using uninterrupted drug with rivaroxaban that seems to have no differences. Also with dabigatran, there is just one paper with uninterrupted dabigatran that even this shows that there was no differences with warfarin. But we are talking about very few numbers, and the study on large number are coming.
So what is your practice now if a patient is referred to you for ablation and they're on one of the NOACs?
If there are on NOACs, my practice and also the recommendation is to stop it shortly before the ablation, 12 hours before the ablation, and restart it immediately 6 hours after the sheath removal. In general, with the dabigatran, the problem that we have seen is that when there is a short discontinuation of this drug, it's more difficult to achieve an ACT level quite higher in the range that we would like to have. So that's why just with this drug, we discontinue a little bit before 24 hours.
Okay, so now patients had an ablation, they're on an anticoagulant. Should we stop it? And if so, when? And how do we decide?
There is a general agreement to continue anticoagulation at least for the 2 months after the ablation. Also for the lesion that we are going to perform inside heart. After that, the issue is much more controversial. If we follow the guidelines, mostly of the guidelines are recommending to don't stop anticoagulation based on the presence or not of recurrences, but just based on the thromboembolic risk profile of the patient. In other words, to follow the same approach as the patient that is in AF. Actually, we have several studies that are using a different approach to discontinue oral anticoagulation after successful ablation shows different data. All the guidelines are mainly based on patients treated on antiarrhythmic drugs, but the number of studies in these years is growing, and even though this study has the limitation to be mostly retrospective with a small population, if we put all together, we collect a good number of patients, and all these studies are going in the same direction. So to risk-benefit an advantage in the discontinuation of oral anticoagulation after successful ablation. Of course, this means that when we follow this approach, we need to be very careful in the intensive monitoring of the patient to check after the ablation also for asymptomatic recurrences, for that if possible to check it, and a continuous monitoring of the patient, including the control of the pulse of this patient that need to be daily for life. We published on JACC a few years ago, maybe the largest study on these issues that include about 3,000 patients. In part of this, more than 2,000, we discontinued oral anticoagulation. In this were 700 patients, about 700 patients that had a CHADS score of 1 and 350 that had a CHADS score of 2 or more. And we also confirm the data of other study in a follow-up of about 2 years. We didn't show differences in terms of thromboembolic event. And
between those in whom was continued and those in whom anticoagulants was stopped.
Yeah. And we saw lower bleeding in patients that, of course, discontinue oral anticoagulants.
As I've read the literature, for first-time ablation without the addition of antiarrhythmic drugs, the success rate's running about 70%.
Yeah.
So if the patient is successfully ablated, there's still a significant chance that atrial fibrillation will recur, but your approach would be to monitor them very closely.
Sure. This is mandatory.
Any loop monitoring?
This is one option that we have today, even is quite expensive to do it. In mostly of the patient, we are doing intensive monitoring with the TTM for different period of the time. In this study, the intensive monitoring was performed in a large population of patients, about 90%. In almost all patients, there was recommended a pulse check daily. Other point where the left atrial contractility was verified after the procedure was good. There was no PV stenosis. So with all these requirements, we discontinue oral anticoagulation after successful ablation.
At 2 months?
At 2 months.
Okay, so this would be even in patients, say, who had a CHAD score of 3?
Yeah.
Okay. Well, this is certainly very important because as cardiologists, we're seeing more and more of these patients. And while the electrophysiologist does the ablation, oftentimes it falls to the practicing cardiologist for long-term management. And these data would be very useful, in fact, with the idea that you can discontinue anticoagulants at 2 months pretty safely.
Yeah. We, based on this data, have already planned a randomized study prospectively. There is a group of physicians that believe in this strategy, the Bordeaux group, the group from Austin, Andrea Natale, Frank Merchel-Iski, Karl-Heinz Cook, that we all together have started this pilot study that is called OAT study, and we hope to see also in the prospective and randomized trial if this strategy will be not inferior to the traditional strategy to continue warfarin based just on thromboembolic risk profile of the patient.
Well, we'll certainly look forward to those results. A common clinical situation that's encountered. Thanks very much for helping us with this.
Thank you for your kind invitation.